Thanks so much for joining us today. Both of those of you here in person and online again. I am Melanie Pipolo. I am Past Program Manager in Mozambique, and I oversee a diverse portfolio with the ECD truly executive support.
Hi everyone, and my name is Ethan Someto. I'm from FAB in Kenya, and I lead the early check development here. And this morning it's so good to see many familiar faces from our donors, our FAB colleagues, and from different corners, and our peers, and our partners, all gathered together here just for a common goal, which is to give children the first start of life.
So we've gathered here today to one, celebrate the work that we've done over 10 plus years to integrate ECD into health and other systems, reaching the youngest children and their caregivers. We're here to discuss learnings over those 10 plus years and to launch a brand new online ECD knowledge hub, which brings together all of the guidelines, training materials, tools, and evidence generated through this work.
And today, we'll be so glad to hear from our main donor, the Conrad Henderson Foundation, the path leaders from Kenya, Mozambique, and across the global health programs, and we look forward to engaging and hearing from you too. So to start us off, we're going to do a short icebreaker. And in Africa, there is a way we do it. And sometimes we can dance to the songs that we used to listen when we were small kids. We all have all manner of sorts of how we do the icebreaker. But today, I'm not going to ask you to dance. But I'm just going to ask you to share a game you enjoyed playing as a child. And maybe I can, and as all of you to say, maybe I can start off and say that when I was a child, growing up in the villages of one district in Kenya, I used to love playing with toy cars. I love the cars. I love them so much. So I used to break them. I used to engage with the toys, just trying to know what is it inside, how can I make it better. And with that, I think I developed passion in terms of loving cars. I love cars today.
Yeah, fun fact you just shared with us that for his 40th birthday was on Tuesday, right?
No, it was May this year.
Oh, it was May this year. Yes. Then he's going to buy himself his dream car.
Yeah.
That's how much your play influences your later life. So really would like to hear from you too. What was those play activities that really stuck with you and influenced how you parent or how you live life or your interests in life? Yes. And for those of you online, please do share with us on the chat too. So,
yep. Feel free to share from any corner.
You want to start here?
You want to start?
I love this when I play store. And as I got older as a kid, it was that store, which I to this day, you can teach them and I get
Thanks for sharing that.
Thanks for sharing.
Anyone else wants to share?
Yeah, I can share. I'm also from Kenya.
Yes.
And maybe some of you know this game.
Yes.
We played a game, we called it Shake.
Yes.
They drew like a grid, and the other team sort of, you had to go all the way to the end, but the other team blocked you off. So you had to move into the squares. And I think it prepared me for dealing with the Ministry of Health. So you had to strategize, you had to work with your teammates to get across. You had to be a little bit sneaky. You had to provide data for yourself to move forward. But it was very enjoyable. I don't know what it's called in America, but and I teach my son. Yeah.
Okay, apologies to the online colleagues. We are trying to make that sound much better. That shocking. Finally, maybe anyone else want to share? Yes.
Hi, Kelly with Pat. I was a nerd when I was little, so I really enjoyed playing school and teaching my younger cousins how to read and do their letters and things like that. And we just set it all up like in the classroom. So
we're glad you're here with us, Kelly. Well, thank you so much for sharing. Truly, I think the reality here is that how we play as a kid really influences our upbringing and later on in life how we think, how we work, how we play with our own children. So really appreciate your sharing today.
Thank you so much for sharing. And without much further ado, I'm now going to welcome and invite my colleague, David Sen, who is our chief lead for integrated maternal and child health development department, who is going to share with us the part of his solution. Thank you. Good morning, everyone. Thanks, everyone, for taking time out of your Fridays, knowing what an extraordinary busy week this is. And next week, for many folks who are headed to New York for UNGA, my name is Devjit Sen, and I will tell you a little bit more about the evolution of this journey. And it has been a journey. I'll start with a few personal stories, and I just think about me as a global health professional. This, in some ways, is my story. When I think about it, I've been at PATH for 14 years, and 12 of those years have been integral or integrally linked to this particular body of work. So in some ways, I jokingly refer to this as my firstborn child. But also in life, when we start thinking about moves, about changes, about transitions, there are certain North Stars, certain fixed principles, or something by which you kind of like orient yourself. And in my case right now in life, it's my mother, who I love dearly. I'm an only child, and I do love her a lot. Until recently, I used to live in South Africa, the beautiful country of South Africa. I'm so happy to see Mark Tomlinson from South Africa with us. And that was one of my quadrants, or one of my sort of guiding principles. And the other guiding principle was this body of work, and just how much of an influence it has been on me and on the lives of countless children, hopefully around the world. So having said that, just a little bit about PATH. I think most of you know who we are. We are headquartered in Seattle, have a large office here, work in a little over 70 countries worldwide on a variety of technical issues. And the early childhood development work is centered within our primary healthcare program, the Global Primary Healthcare Program. I'm not going to go into the details of these slides. These are very dense, but just to give you a flavor of the program. Which focuses on contextualized innovations around partnerships that are transformative and evidence-based decision-making, which result in tailored primary healthcare services, resourced primary healthcare systems, and resilience. And I think we're all aware that one of the biggest drivers of resilience is improved early childhood development. So why is it so important to promote early childhood development?
Underlying societal causes, poverty, as well as high societal prevalence of HIV, diseases, crime, and we know now, sadly, conflict and disasters in many parts of the world. This is a slide that is quite familiar to many of us, showing this how physically different the brains are of children who have optimally developed versus children who have been neglected, who have not received the stimulating or the stimulation and sort of caregiving, quality caregiving required for them to reach their full potential. But what's important to integrate ECD into primary health care? Until, and I'll come to that in a bit, until about 6, 7, 8, 10, let's say a decade ago, it was almost believed, and even on certain quarters to this day, that early childhood development equals to pre-primary school. Well, the problem is that human brain development is most rapid during pregnancy when the child is in the womb and those first few years of life, 2 to 3 years of life. Therefore, we get the biggest return on investment, the greatest bang for buck, if we intervene in those early years when human brain plasticity is the great, and hence the importance of intervening in the early years. Then, why primary health care? Because in the early years, primary health care is the main platform through which most caregivers and children interact. It's usually not education, And unless we're dealing with certain vulnerable demographics, it's not social protection, but it is primary health care universal. Once again, something that's very familiar to most of us, nurturing care framework. Many of us in the room have played a part in its articulation, and since 2018, its domestication and rollout. But the nurturing care framework essentially for the first time said that essential health services have to expand their mandate to include not just child survival, but ensure that children thrive and reach their full potential in life. And importantly, and responsive caregiving. So, once again, a rather busy slide, but the reason why I'm showing this is that I want to reinforce that the work that we have been doing, really catalyzed by our amazing partner, Conrad and Bill Foundation, been a friend, a thought partner, that charged us and really kind of motivated us to think beyond business as usual. And I think the first thing is it's important to take a systems-based approach. We can't just train, we can't just build capacity, we can't just work at the policy level, and we can't just do research. All of these need to come together. It's not necessarily easy, it's not necessarily fast, it may not be efficient. It takes time, but you have to intentionally and deliberately strengthen these blocks. Whether it be advocating for inclusion of missing ECD content in policies, guidelines, tools, in SOPs, in indicators, in job aids, in quality assurance tools, whether it be capacity building through in-service and pre-service curricula for service providers at all levels, whether it be formative assessments of human-centered design to understand what works, what doesn't work, and most importantly, working hand in hand with local partners, whether that be CBOs, national NGOs, and most importantly, government at all levels. But it's also important to ensure that we're not sort of using a one-size-fits-all model. Once again, this is a busy slide, but I just encourage you to kind of focus on the shape and the interventions and the colors. So green is where we want to intervene universally. So light touch developmental monitoring, counseling at universal touch points. But then as children get exposed to different levels of risk, the intensity of counseling needs to increase. But at the same time, we're dealing with smaller numbers of children. So in other words, we're able to provide more intensive support to these children while also ensuring that everyone receives a modicum of universal services right down at the bottom. So now the journey over the years. And for those of us who remember the Millennium Development Goals, seems like a lifetime ago, the MDGs do not talk about thriving children explicitly, at least. They talk about primary education, maternal and child survival, and that was really sort of the North Star, the countries that partners were following. And in 2011, the Hilton Foundation launched its Children Affected by HIV/AIDS strategy, which at that time was a trailblazer because for the first time ever, we were hearing how important it was to promote children's development, not just ensure that they survive, but they reach their full potential in life. So back in 2012, when we first started this work, when I was a much younger man with more hair and 20 less pounds on me, this work featured working with community-based organizations in Kenya, in Mozambique, using home-based counseling, group-based counseling, a very comprehensive counseling package covering multiple technical areas, but also working at community level around child-friendly playgrounds, play spaces, ECD centers, and what have you. But we gradually realized that there was one area which was a critical gap, and that was promoting ECD for the youngest children, 0 to 3. There was, at least in Kenya, where I was living at that time, there was an awareness that preschools were important, that children, if parents could afford them, or if there was a preschool nearby, that children should go there. But at the same time, very little was happening for these very young children. And remembering what I said at the beginning, the answer was once again loud and clear. We needed to intervene at the level of the health system, both at facility and community levels. And so back then, we first worked in adapting the Care for Child Development package, the WHO UNICEF package, making some basic adjustments, adding content for the prenatal period, making it a little more conducive to adult learning, having reflections, role plays, but also we use the same materials for community and facility-based workers, which we realized maybe was not a very good decision when we did the evaluation. We were also noticing that service providers had a predilection of kind of like not integrating, but adding this on to the detriment of other service delivery areas. So moving on, what we then decided was, well, let's co-create through formative assessments a set of counseling cards which tells service providers what messages they should be sharing at each specific touch point for children of each specific age. This was a beautiful set of counseling cards. I found one set lying in a friend's basement after I moved back here. I was like, wow, this still exists. 35 gorgeous, glorious, colorful cards, very detailed, very beautiful. And at the same time, emphasizing not just technical content, but also interpersonal content. Because, you know, counseling is not just about saying, it's also about listening. It's about the opportunity to ask questions. It's meant to be a friendly, warm conversation. So this was our first comprehensive counseling tool. And you can see this this gentleman holding up the set of counseling cards. It's quite thick, lots of beautiful content. And we kind of honed in on what we call our core package of interventions. The core package being monitoring children's developmental milestones and counseling caregivers on how they could play and communicate with their children as an integral part of every service that they were offering, whether that be well baby clinic, care for a sick child, whether that was a child that was exposed to HIV who had come in for an HIV specific service, but integrate. And the integration was quite laissez-faire. Healthcare workers were told, well, if you have 2 minutes, do what you can. If you have 20, thank you. If you have 30 seconds, just one quick message. We understand you're busy. So it's very laissez-faire. Similarly, at community level, counseling and developmental monitoring provided by community health workers, both government, the case of Kenya, and less so in Mozambique, but also through volunteers, wide network in Mozambique. And play sessions in health facility waiting areas. We realized that health facility waiting areas are unfortunately very child unfriendly. Children and their parents spent a lot of time waiting to receive services, and we sought to make use of those lengthy waiting periods for parents to play with their children and receive some counseling on how they could play and communicate with their children. So this was kind of like the essential package, the package that we decided had now been tested, and I'll just show you a few results in which we decided to scale up. So our initial evaluation results showed that healthcare workers were able to take this up, that if they were able to take up the new knowledge, they were able to improve both their technical quality of their counseling, as well as the interpersonal skills that they had learned. At community level, we saw that there was a significant uptake of all the content that we were providing through the trainings. This was an assessment that was done in Mozambique, comparing a district where training had happened, a district where training had not happened. So from a point of view of sort of like operational feasibility, as well as of course acceptability, we had collected acceptability data, it did look like service providers were able to take up this new content and integrate that into their daily routine. So now that we were convinced of that, we decided we'd take this package, those 3 interventions that I measured, and then sort of think about how they could be turbocharged and scaled up. And the first big point was, well, that beautiful pack of 35 counseling cards, great reference material, but if you're thinking of scale up, no one's going to be able to print that. Government for sure, not even partnered. So that was condensed into what we then called a mini package. I think it was what, Lana, 6, 7 counseling cards, but a fairly slim set of counseling cards. And then there were 2 posters, which condensed all of this content into one on developmental milestones and one on age-appropriate play and communication activities. And this is what sort of was, as I said, turbocharged to scale up. so that all health facilities, government health facilities, and all government community-based service providers in one county in Kenya, Siaya, one province in Mozambique, were offering these services, reaching an incredibly large number of people. And I think, to the best of our knowledge, this was the first time that this level of scale had been achieved. And as this expansion started happening, this is also around the time the Nurturing Care Framework came on the horizon. A lot of global attention, a lot of global excitement around the 2018 World Health Assembly. And this was also when other donors, other partners started getting excited and interested about this body of work. So in Mozambique, for example, we entered into a public-private partnership facilitated between the Hilton Foundation and USAID to scale up to the whole of Maputo province and just ensure that there was blanket coverage. Tools were shared with partners in Malawi and Tanzania, fellow Hilton partners, and technical assistance was provided via additional donors, the Van Leer Foundation, TREC, which worked in cocoa growing communities in Cote d'Ivoire, to take these approaches to very, very unique and I would say somewhat different settings, but also showing just how relevant this content was. Give an example in Cote d'Ivoire. These were mostly group sessions as part of nutrition programs in the cocoa growing regions of Cote d'Ivoire, and in Turkey, an urban parenting program. And then after that, we were able to enter another country as the Bainum Family Foundation funded us to take this work to scale in Addis Ababa, another massive geography. And we were able to cover the whole of Addis Ababa with these services, build capacity of government. And another donor, Big Win Philanthropy, bought into this and said, well, can you take this work to conflict adjacent regions up in northern Ethiopia? And we did that as well, where we integrated not just developmental monitoring and counseling and play sessions, but also, and I'll come to that in a bit, maternal mental health services such as screening and counseling on depression into efforts to reconstruct primary healthcare after the destruction wrought by the war. And we saw some pretty impressive results, a significant decrease in moderate depressive symptoms in these areas. And this shows one of these support group sessions taking place in northern Ethiopia. And there were significant advocacy wins during this period as well. So as I mentioned, if you remember that slide which showed the various pillars, it's not just important, it's not just about intervening at the level of service delivery, it is essential to build an enabling environment. So we worked with our government colleagues, with other partners such as KMED and Kenya, and so many others, to advocate for the integration of missing ECD content in child health policies, tools, guidelines, indicators, surveys such as the Demographic and Health Survey. And I think in many instances, for the first time ever, when these policies and guidelines were coming up for revision, for the first time ever, child health policies or guidelines were including an ECD component, because hitherto, ECD was considered to be the purview of education, not the Ministry of Health. But as we moved sort of into the COVID years, we're realizing that this beautiful, broad brush strategy was leaving behind certain vulnerable groups such as adolescent girls and young women who are pregnant or who have already become mothers, girls who are children themselves, not physically or mentally ready to be mothers, but who have become mothers. And we know just how prevalent teenage pregnancy is in so many of these geographies. We also realized that we were leaving behind children with disabilities, young children with disabilities, because a lot of disability and inclusion services tend to focus only on older children and adults, not on the youngest children. And even when those children receive services, they fall through the cracks and don't receive referral care. So this is when we started testing some innovations focusing on vulnerable groups. For example, group-based peer support sessions leveraging the DREAMS platform, the USAID DREAMS platform in Kenya, bringing these adolescent girls and young women who were being brought together in the DREAMS platform, but including components on parenting as well as mental well-being, and also seeing a significant decrease in depressive symptoms, as well as an improvement in interpersonal communication with their partners, which, as we know, is a driver oftentimes of poor mental well-being. And this is a photo of a safe space. They're very simple. They're usually in church compounds and health facilities, but where these girls meet with a facilitator who often is another woman or a girl in a similar situation. And this is where such integration happened. I mentioned maternal depression or poor mental health. So in Mozambique, we pilot tested the ability of frontline medical professionals, maternal and child health nurses, to provide counseling on maternal depression, as well as screening on maternal depression, thereby task shifting from professionals, because professionals, the tertiary professionals, are not at the level of primary healthcare. They're sitting in the district or the provincial hospital, but in a frontline clinic, it's usually an MCH nurse. And we realized that not only was this feasible and acceptable, but that more than 70%, or rather, nurses were able to detect more than 70% of cases with accuracy, thereby suggesting that this is something which can potentially be scaled up. Clients, close to 3/4 of clients, said that they found this acceptable and that they were happy to discuss their problems or problem solve with nurses. And in the breakout sessions, we will discuss more thoroughly, but you'll have an opportunity to interact with the materials, as well as hear from one of our experts around how this work was rolled out. Another innovation was working with children under 5 with disabilities. In Mozambique, we partnered with a fantastic local organization called ADEMO. Until then, ADEMO was mostly focusing on older children. We worked with ADEMO to look for these young children under 5, support them with simple assistive technologies developed in the community, strengthen referral networks. If if specialists were not present, bring specialists over, but also bring parents together in peer support groups using an Ubuntu curriculum, which once again, one of our specialists will tell you more about in one of the breakout sessions. And we saw a fairly significant increase in both the number of facilities referring children with disabilities, and also dramatic increase in the number of under 5 children being identified by this CBO that we worked with. And you can see in this photo on the left, these are parallel bars made with locally available materials. On the right, you see a pair of trousers that have been stuffed with rags and cotton and other things. And these help with positioning children who have cerebral palsy, for example, so that they can sit upright, they can be fed, but using very grassroots, very simple materials available in the community. And the last innovation that I want to share is, and this is sort of kind of where we are right now, is human-centered design, to look at how we can how we can refine the work that we have been doing all these years and ensure even better quality of counseling, even better uptake of key messages. And we realized that while there was a high level of acceptability and feasibility, a lot of the counseling messages focused on toy making. It focused on simpler stimulating activities, not very complex stimulating activities, not so much on the responsiveness, but as I mentioned, the toy making, there was a lack of counseling on age-appropriate play and communication activities that were more complex around bonding with the child. Job aids were there, but they're mostly used as referral materials rather than job aids that were being constantly referred to. So we sat down with government, with service providers to understand, well, what are the barriers? How can we address those barriers? Let's dream about some solutions and then let's test them. And so after testing the solutions that came out, and again, one of us will discuss this in the breakout rooms, is reinforcing counseling at antenatal care, where already this message that children can hear in utero, that they can recognize the parents' voices, that they can sense stress or happiness. That was just such a powerful hook that we felt, let's reinforce counseling here. Parents or mothers, to-be mothers, usually bring someone with them to give birth, and they spent up to 24, if not more hours in a health facility giving birth. So strengthening counseling at this particular touch point, simplifying the play sessions in health facility waiting areas, making the instructions simpler, but also having some task shifting so that some of the counseling gets moved into the health facility waiting areas, because we realize that due to extreme workload in the consultation rooms, the quality of counseling was probably not as good as it was supposed to be. To have some of the counseling happen outside and then let it be reinforced once you're inside the health facility. And in Kenya, what we heard was that health service providers said, we don't need new tools. We already have the milestones and the counseling messages in the new mother and child handbook. Let's do a better job of using that. And we listened. And we worked with our partners to develop an SOP that would allow them to use that tool to provide these key messages. I'm not going to go into the details of this data, as Lana will introduce the Knowledge Hub. She will tell you where you can find all of these snippets in a range of beautifully written briefs, if I may say so, which should make for some very interesting reading, but showing that indeed that refining these solutions did lead to tangible changes. So, Lana, do you want to just come in here now, maybe? Or as you're setting up, I can finish. This is my last slide. So we are constantly thinking. Our brains are just twitching, and we're thinking how we can, innovate and continue doing more work. So, for example, there's childcare, and this is an area of I can speak as Lana is setting up. So there's childcare, and childcare is an area, as we know, that is increasingly popping up as an area of interest. But childcare on its own is not sufficient. There needs to be tighter linkages with primary healthcare, with nutrition. How can we make childcare more holistic? And we're doing some excellent work in Ghana to test out some of these models in Ghana. We're also taking this mental health work to scale in Ukraine. Lana, my colleague and friend here, who's Ukrainian, is leading some innovative work in Ukraine to take some of these models there and see how they can be contextualized and implemented there. And in Kenya, we're looking at ways to strengthen newborn care, essential newborn care for newborns that are small or sick, that are, we're vulnerable, and include aspects of mental health support for the caregiver and early childhood development into their continuum of care. So having said that, I'm going to hand it to Lana to show us a short video. Over to you.
So it's not really me, it's a video. So just to give you a taste of one of the solutions that came out of human-centered design in the maternity ward, which I think is probably one of the most innovative things we've done. It's translated from Portuguese, so if you hear some funny English, just bear with us because it's a draft video. Hopefully as we refine, we'll get better versions of it. But
counseling on early childhood development in the maternity ward at time of discharge. Invite mothers, companions and fathers who are present to participate in the health talk. Start by asking two experienced companions to share their experiences on how to care for the baby and mother at home after giving birth. Praise the companions for sharing and underscore the helpful practices. Add a few practices for taking care of the mother and the baby that were not mentioned. Make use of the posters on the walls. If necessary, correct any traditional practices which are not good for the health of the mother or the baby. Invite all the mothers to practice good positioning and attachment to the breast. Remind mothers to talk to their babies when breastfeeding. Walk around, support, and praise the mothers. Emphasize the benefits of exclusive breastfeeding in the first 6 months after birth. If the mothers or companions already know about the benefits of massaging babies. Listen carefully. Add that massage calms the baby and relieves colics, helps the baby to feed and sleep better, and supports baby's growth and weight gain. Invite the mothers to look at the poster on infant massage. Demonstrate how to massage a newborn from head to toe. Do not forget to talk to the baby during the massage. Invite all mothers to practice massaging their babies. Walk around, support and praise the mothers. Help them talk to their babies when massaging them. Share messages that the mothers and companions should pass on to the fathers. Fathers should help the mothers give bath to the babies or change their diapers. They can enjoy playing and talking with their newborns at the same time. Men can also do laundry and cook while women rest and gather strength. Finally, fathers must see to it that the new mother eats well so that she can produce milk and take good care of their baby.
Very good. So we are bringing in the practice that's already being promoted in the maternity ward and adding on layering, right? And also speaking during baby massage, of course, right? So really just making something very simple instead of bringing on new package, just picking a few practices and adding on existing counseling that's already happening in the maternity ward. I think I will ask my colleagues to take over. Thank you. Well, that was a wonderful presentation by Devjit. I hope you all felt as inspired, and we feel very proud to see our work presented and summarized in that way. Yeah, 12 years of work is no small feat, and it's not easy to really demonstrate the richness of the work that is there. But that's why we've created a fantastic resource for you all to be able to access. And you should feel very special because you're getting the first view of it. It's being launched today. And to officially do that, I'm going to invite Lana to come back here, please.
Yeah, thank you so much. As we are setting up, and Lana will be coming in shortly. I just want to take this opportunity to invite Lisa Boma from the Conrad and Hilton Foundation, the Global ECD Director, to come and speak to us, to just reflect about this work that has been shared previously by Devjit and the long outstanding partnership that we've had with the Hilton Foundation. Thank you. A round of applause.
Sorry, I got a little bit ahead of myself there.
So, first of all, it's so good to see everybody in the room, and I can't see you, but thank you for being there online. And I just want to really appreciate the PATH team. This has been an incredible period of, you've seen much rich innovation, experimentation, and learning. And Devjit, that was an incredibly clear, I agree, really interesting presentation. It was wonderful to see the journey, and it's great to see some friends online. I just, it's great to have a moment to reflect. And, I started at Hilton Foundation in 2013 and just had the joy of thinking about this health work. I think it was late 2013 at a meeting in Cape Town, where we realized, wow, we were missing health. And there were these touch points. And, PATH said, well, let's figure this out together. And PATH started this work. Apparently some work had already started in 2012. I just learned about today, but it was a time, again, many of you will recall, now we have this understanding about health and social welfare, but it was really about education primarily when you talked about early childhood. And there was very little attention and understanding of why health was important. And I think Devjit's already talked about this universal platform that serves so many children. and you've spoken a little bit about the journey, but I was just thinking about, 2 years later, the third Lancet series on ECD came. That was really emphasizing a call to serve the youngest children in the health sector. So that sort of helped us. And then we started the discussions in Geneva with the WHO, with many of you in this room. And that was a real thrill because I still remember the meeting where there were lots of folks that suddenly were in the room and we were talking about the health sector and people got it. I come from public health, so, sort of had this public health approach to ECD, but a lot of the education colleagues we worked with, that moment where they saw it was thrilling. And I know PATH colleagues, I think Matthew's on, will remember that moment and remember then the opportunity to start working on the nurturing care framework. And so many of you in this room and online contributed to that process. But it was PATH that had the government partners that could come to those early meetings in Geneva and share, we're doing this in Mozambique, and here's why we think it's important. And that evidence from on the ground was so critical for developing, again, all the global guidance, including the guidelines, right? So the nurturing care framework was in 2018, and just before 2020, just before COVID shut us all down, we had the guidelines. And I really want to commend PATH for the work to both do all the work to support government partners and others at the country level, but also really contribute to this global field building work because it was so important. And yeah, it was working really at both levels and making those connections. And we know that now, here we are 10 years later, there's a lot of work to be done, but we've got broad understanding and support for this work from government leaders, health professionals, a range of non-governmental actors, including key folks like local pediatric associations in country. And we know from other health innovations, whenever you introduce something new, you've got to have local trusted leaders that are advising the Ministry of Health. It can't be an international NGO or a donor. So I really just appreciate, I think, the progress we've made, but also the opportunity like today and beyond today to continue to reflect on the key learnings and to talk with government and get their perspectives, which I think are so, so critical. And I know we're hungry to hear more from them, and acknowledging that in addition to celebrating the successes, the learning from what hasn't worked is critical. And I know PATH has a lot of rich experience with that I think you touched on, Debjit, but just really appreciate that openness to share what hasn't worked. I think our overall reflection, is that you shared, Debjit, there's acceptability for this work, right? And health workers early on have said, this is part of our job, we want to do this, but the feasibility continues to be a real challenge. And we haven't figured out how to deliver this at scale, sustainably, with fidelity. And we know that we're really working with health systems that are largely underfunded, understaffed, and overburdened. And we've all been, many of us, at facilities where you see the long line and you see that one clinical officer or nurse, and you know how hard it's going to be to take the extra time to do the extra counseling. So I think we've reflected at the Hilton Foundation about the need to really zoom out and understand better the way health services operate. And that's required looking at workforce financing, community engagement, and health management data, and thinking about what we can add on to sort of busy health worker responsibilities now, what requires more upstream advocacy for better investment in the systems, what policy levers to enable health actors to better deliver support, such as policies around compensation for community health workers, as well as their training, what's their caseload. Sometimes we don't ask, we all just want to add on to. When you learn, I think in Kenya, it's one community health worker for 100 families every month, and it's often more. So we're also likely not looking at one model that we're going in and trying to convince government, but a menu of approaches that can be contextualized by local actors. And I was really thrilled when PATH brought in the human-centered design work, and it was great to hear how you've done more of that work to really innovate together with. We recommend that we're often needing to start with the government folks and to understand what health challenges they're facing and think about layering these additional onto existing. It might be stunting, it might be low levels of breastfeeding or skilled delivery, but that we have to do a better job of really supporting primary health care and integrating these less understood elements as part of their priorities if we are going to ask them to embrace this and to invest in it. And don't forget, we're looking at that broader ecosystem of actors, including social welfare and the connections between health and community. We're really interested in a few of the populations that PATH really did groundbreaking work with, young mothers and children with disabilities. And again, PATH, really excellent work. That work in Mozambique, I think, has informed some of our thinking. The DREAMS work, I know, was really important. So we're continuing to do more with those populations and invest in them. So this work continues to be a priority for us. And PATH's really, your lessons and your foundation has helped a lot of the partners that continue to work. UNICEF's done a lot of really interesting work, including looking at financing for primary health care, since we want to have a better data and a better ask regarding investments in primary health care. We were concerned that some of those investments may be decreasing. We're looking at national digital health work in Tanzania with D-Tree. PATH did some really interesting early digital health work in Siaya. It's great that R4D's here. They're looking at what we should do systematically to enhance primary health care. They're going to be coming out with a roadmap that I think is going to be really interesting. And the WHO continues to play its role. And USAID, really an important partner. PATH, we had that really interesting collaboration in Mozambique, and we're continuing to go deep with the Children in Adversity team, as well as missions, to really take them to see some of this work and to encourage USAID at the country level. So I think in closing, we're really looking forward to continuing this learning journey with you all. It does take time. It's only been a decade. We really want to play our role in encouraging broad dissemination of PATH's critical lessons and tools, and I hope you'll all join us in doing the same as we continue to work to set all children on the path to optimal development. And again, just want to really ask you all to join me in applauding and congratulating the PATH team. So thank you. Bye-bye.
Thank you so much, Lisa. Those were very, very wonderful, inspiring words. And I must say that on behalf of the ECD team at PATH and our global regional teams from Kenya, Mozambique, I just wanted to say thank you. And you have been a very good partner, a friend, and more in this journey for the past over 10 years.
Yeah, and can you tell how excited I am about this next speech? That I got a little bit ahead of myself. But yeah, we really wanted to, as Lisa said, put together our learnings, the tools, the materials in one single location. And we're really, really proud to invite Lana to share with you. She says this is her baby. Yeah. Davjit says this is his firstborn baby. Lana, this is probably your 10th born baby because all these interventions have you behind it. Yeah. So please join us in sharing with everyone about this wonderful knowledge hub.
Thank you. Lana.
Really been with PATH for most of those years and really was able to see what Davjit has talked about, the evolution, the 6 packages the thin packages, and everything in between, right? And the exciting last iteration, which is the human-centered design work. So for me, it's really personal, like I've lived through it. So it was very interesting to kind of work on the knowledge hub and try to kind of tell a story. And maybe when I was trying to think how to tell a story, you know, I went and looked at other knowledge hubs, right? There is like a Khan knowledge hub, there is ECDAN, kind of information resource. There is a nurturing care resource page, right? So I was trying to see like how have others organized, what is there. And then also my personal experience, because for the last 3 years of living in Mozambique, I was running a community library. And one thing I realized very quickly, it's not just about putting the books out there and thinking that kids and adults and teenagers will come and just, yeah, wow, this is a fantastic book. I really want to read it, right? You have to turn it in such a way that they see the cover. You have to organize in a certain way by topics, by, you know, groupings. You have to talk to them and see like, what are you interested in? Do you want to know more about dinosaurs or about stars or about like teenagers like yourself, you know, what they're going through? So you really have to know your audience and then curate whatever you have to offer to them, right? So it's not just like putting the stuff out. And so that's, I think, my personal experience that I try to apply to the Knowledge Hub as well. A bit of curation, not just like putting the stuff out there and then letting people figure out for themselves why things are there, but really kind of tell a story. And so if you, I don't know if you guys were able to access whatever you have in front of yourself, if it's a phone, we try to make it phone friendly. So hopefully it is, it just doesn't show as many photos, but its computer is a bit nicer version. So the idea is to really kind of tell a story. That's why you see, maybe it's a bit of text heavy, and I would like to get your feedback because this is a living organism. So hopefully we can improve it. It's like you're thinking first version today. Hopefully there'll be like several versions and iterations until it comes and becomes really useful resource, living resource. And we also try to acknowledge the partners we worked with as much as possible and cite the kind of original inspiration behind the packages, the care for child development, the thinking healthy, caring for caregiver, nurturing care for ECD framework. So really always acknowledging where the ideas came from, where the inspiration came from. And I think the most exciting part is here, where you can see resources by topic. I don't know if you can follow. The first bit, the evolution of approaches and tools, is really what Debjit talked about. It really goes into our history, the initial adaptation, the next adaptation, and the current, kind of not the current, but the most recent adaptation. And if you click on any of those, you will see sample materials. We haven't put everything. We don't want to overwhelm you, but they are representative of the specific phase and what we were trying to do in that phase of our work. Understanding caregivers and health services, that's what you will find a lot of formative assessments. We were never kind of, I would say, big on funding, or like we didn't do a lot of huge studies, but we have a lot of small formative assessments, which I find really interesting because you do in-depth interviews with 15 mothers who are adolescents and learn a lot about them, like how can you actually make program useful to them, right? Or you go and spend hours reading physiotherapy registers and calculating how many have Apgar scores in the physiotherapy register listed, and compare Apgar scores with the burst asphyxia. And like, wow, it's actually Apgar score is 9 to 10, but the children have asphyxia, so something is wrong, right, in the registers. So this type of nitty-gritty analysis, you will see some examples there. And they're kind of very technical, but for some of you who might like this type of technical analysis, you will appreciate that. I would like to screen share for this, I'm sure. And so maternal newborn health. So you will see the sections are structured differently. Some are structured historically, some are symmetrical. Like here in maternal newborn health, you will see a section on antenatal care, postnatal care, and emerging work on care for small and sick newborns. And you will see an array of documents. Some of them are job aids. Some of them are training materials. Some of them are examples of registers. We were able to successfully integrate some of the ECD indicators. So we really tried to give you a taste of what has been done and show you very different documents. And not just from Kenya and Mozambique, we've had funding from the Conrad Hilton Foundation, but also we brought examples from other countries such as Ethiopia and Zambia, for example. So you can see a register from Ethiopia here, for example. And there is always a short description and a bit of a story in the main section describing the materials. So maybe just to show you the last session, you know, we have been working on the health sector primarily in the health sector, but by virtue of relationships you build over time, you become multisectoral, and you understand that this work is multisectoral, right? So we've been dabbling with other types of programs, such as parenting education, and really delivered outside of health sector. So this particular pilot was done with agricultural associations because they come together and they're caregivers of young children, right? So we use them as a platform, parenting packages. In Mozambique, we went ahead and supported community preschools programming because that was the ask of the ministry. We were part of the OVC project, and that's what they wanted and needed. So we attended to their needs. We worked a little bit in child subsidy in Mozambique, where when caregivers come together in care group to receive the subsidies, they also have a care component. And so care component was integrating nutrition and ECD in it. And just really training over 60 community-based organizations to integrate as a support OVCs, or vulnerable children, to also monitor milestones and support their development. You will see some materials on advocacy. We've been partnering with the Khan Foundation and with a course, which many of you know, Science of ECD. But we've really, in Mozambique, dabbled with the course quite a bit. I don't know if they're angry with us or happy with us, because it's over 60% Mozambican Science of ECD course. And we're actually going to train the partners in it as one of our handover activities, ECD network partners, because we really try to bring the data from Mozambique, the programming from Mozambique into the Science of ECD to show that it has been domesticated. And if you talk to our government and the ministries, that's what they want. They don't want programs from elsewhere. They want to know what has been working in Mozambique and what data do we have that really justifies the need for this programming. And then you will see a host of communication materials. We had some very talented partners across countries with whom we produced radios and videos and even songs. Songs that are in local languages, but you can get the flavor just by listening to them and get a bit of a description and storybooks. So we went above and beyond health sector and really tried to grab the opportunities, including during COVID, to kind of talk about ECD, but address also the issues of the that were pertinent. So just to show that there are also links to other knowledge hubs that we have found. So if you know of any other knowledge hubs or resources that should be listed here, cross-reference here, please let us know. And vice versa, if you think that some knowledge hubs should cross-reference this one, please help us make connections so we do that as well, so people can have access. Dickens and Melanie, can I ask you to do the task? No. So my colleagues are very creative, so they came up with one practical activity so that it's not just talking, but you actually can get into the knowledge hub and try some of the resources for yourself.
Just need to do a little bit of a transition here for those on the line too. Were you all able to access the Knowledge Hub? Yeah, great. Because this next part, you have to be on the Knowledge Hub. So really, let's go on a treasure hunt, right? Because we believe that we really have some treasures. Hope you on the line can also access, because this is for everyone. Good? All right. Shall we do our treasure hunt? So there's the first treasure that I'd like you to try and find out is the ECD in antenatal care visits poster from Kenya. Yeah, I'm going to give you 1 minute. And the first one to find it can raise their hand. Yeah, you did? Great. How's it looking? How about you, those on the line? Were able to find it? Got it? Great. How about if you can find a training video on playbox sessions in health facility waiting rooms from Mozambique? Again, 1 minute, and the first one to find it can raise their hand. Yeah? Well, that was quick. Yeah, you did? Great. Cool. So, all right, Jamie, since you found the first one first, can you tell us what was the strategy that you used to find the materials? Uh-huh. Great. What about you? What led you to the health facility waiting areas training video? Oh, that's very, very smart. So for everyone, how easy or difficult was it to find the materials? Anyone had any difficulties? Emily? Yeah. Okay. Oh, all right. Or maybe that's something that we need to improve on that. That's why we're asking really, this is the first opportunity that we have to share it with everyone and then to also gather your feedback to see what we need to improve before you share it wider as well. Yeah. And any recommendations that you have, to improve it, to make it easier to find? Was something not so intuitive as you had hoped? Yeah. Lana, do you want? We have things sorted by, can we sort it by country? Can we filter materials by country? Yeah. Anything else that you found that was missing? Yeah, sure. Yeah. Yes. Materials abuse. Yeah. Thanks. We thought the same thing when we were like browsing through it. Any other things that you thought, would be better to have it a different way? Yeah. Marcus. It's going to be linked to the PATH website. Is it already? So, work in progress. All right. Well, thanks. And let's see if I have anything on online. How do you anticipate the hub will evolve in the future? Will you keep adding new materials? Have you considered uploading materials from other countries and partners? Lana, do you want to take the questions? Yeah, please. The virtual thinkers. So thank you for the question. I think it's Matthew, I suspect. Sure. Yeah, I think definitely we want to make it a living organism. Some are draft, and you will see like there is a big word draft, right? Draft because there is a going internal PATH review or government review. So there is a host of materials from Ethiopia, for example, that's coming online. So hopefully within a month or so we'll have them. And yeah, we would like to be able to share materials from other countries and partners. We're trying to keep it with a specific focus. It's, I would say, 90% health focused or primary healthcare focused, right? So we'd like to continue because knowing that there are other websites doing other job, right? Looking for nurturing care holistically. So we don't want to duplicate and repost, but I would say anything related to primary healthcare, especially in sub-Saharan African context, for sure. Let's see if there are others. Yeah, thank you. So Mercy, one of the participants had a question. If they, because you've seen that all the materials are downloadable, we try to put them in high resolution so they're actually good quality and print ready.
And if partner wants to use the materials, they will be so happy you can use them. There is a feedback function. I don't know if you've seen it. It's on the bottom of every page, and it says share feedback, and it asks which material you have used. So you can name the material or the manual. What are your impressions or thoughts, or what are your experiences if you have used it, not just looked at it. And if you have any questions, or like this part really didn't work out for me, do you have any additional materials related to this particular job aid, for example, right? And it will come back to us. We will receive the feedback, and we will definitely back, and there is an option for you to put your email so we can respond back to you. Yeah, so that's the easiest, but then you can also reach out directly at PAS if you want more intensive engagement. Thank you.
Yeah, thank you. Thank you so much, everyone. Thank you so much, Lana. I just wanted to request for a round of applause to Lana. Yeah, thank you so much. And you will have the opportunity to continue interacting with the Knowledge Hub and provide us with any feedback. We will appreciate those feedbacks so that we can make it much, much better as we move on. And so I think at this particular juncture, we've earned ourselves a coffee break. And we are just gonna take a 15 minutes break just to do coffee, to do bathroom. And our bathroom is just right outside here, and our coffee is gonna be served there. So thank you so much, and a round of applause to everyone. Shall we? To the online colleagues, we're just taking a short break, and we will be back soon.
Well, while you settle back into your seats, I hope you've had fun up to now. So I think Debjit really talked about some interesting things that we've done in the last 5 years of the program, gaps that we identified over time. I'm gonna turn this back on. Gaps that we identified over time. We were always doing developmental monitoring, using milestones to identify children who were behind and who needed to be referred for further treatment. And even with those developmental milestone monitoring interventions, we were pretty sure we were missing out on the children who really needed the most support. So that led to us trying to identify partners who are already working with children with disabilities and building their capacity to provide community-based rehabilitation. We also, as the evidence came to fruition, and we got more information around how caregiver well-being affects parenting. We also started giving more attention to that. And then finally, as Lisa said, we're still trying to crack the nuts on how to sustainably deliver these services through systems. So that's where human-centered design really came in, to hear from providers, to hear from caregivers what works, in the context of overburdened, understaffed, and underfunded health systems. So now I'd like to give you an opportunity to do a little bit of a deep dive into that, short deep dive. And we're going to break into groups and go into different breakout rooms so that you can interact with the materials and immerse yourself a little bit into how those are used in real life scenarios.
Yep. Thank you so much, Melanie, and welcome again, everyone. And as we are going to break into groups, I'm just gonna call upon my colleague Sarah to just come and take us through in terms of how we are gonna move forward to the group for the deep dive. Thank you. Welcome.
Thanks, everybody, and really exciting that we get to move forward with maybe the best part of today, just interacting and experimenting with the materials and talking with our experts. So we're going to break into 3 groups, and we're going to count off by 3s. And maybe if you don't mind, Helen, if I could call on you to start the counting off all the way in the back. So just, in order going 1, 2, 3, and then we'll put you in 3 breakout rooms. Excellent. Thank you, everybody. So you passed the 1, 2, 3 test. So we're going to rotate about every 15 minutes, and the facilitators will help you do that. And we will start with breakout room number 1. And Natalie will be moving our virtual participants to breakout rooms as well. So if you're online, hold tight. We will put you in breakout rooms as well. So all number 1s, if you want to go ahead and get up and move towards the door, you will be with Deb Jeet in room number 1061. And after that, you'll be moving to room 1004, and we will help you do that. So Deb Jeet, if you want to just raise your hand where you are. So we're actually going to be right here in this room. So if you're number 1, just move on over to that table. If you are a number 2, you will be with Melanie, moving to room 1043. So Melanie, if you want to raise your hand, all number 2s, please head out with Melanie. Gather up with Melanie, and she will move you to where you need to be. So again, number 1 at this table here where Natalie is, and number 2 with Melanie. The number 3s, we haven't forgot about you. You will be headed to room 1004 with Lana and Dickens. So Lana, if you could just raise your hand, and Dickens, maybe gather in that area there so not to confuse people. So the back right, we have Dickens and Lana. This is number 3. And again, we will help you move every 15 minutes. And people online, just hang tight. Have fun. Have fun, everybody.
All right, we're trying to understand how we can do the virtual breakout. So thanks everyone. Thanks for your patience. Thanks for hanging in there. So the table, the virtual table, which you can't see online, but what I'd encourage you to do is go to the Knowledge Hub, go to the maternal and newborn health and the child health tabs, and we are referencing materials that you can find in there. So as I'd mentioned in the initial session, after almost 10 years of working at scale, using that core package of interventions, scaling that core package of interventions, we realized that more needed to be done to understand how we could improve the quality of counseling, of service delivery, how we could improve the uptake of key messages by caregivers. And so we embarked on a process of human-centered design, bringing together service providers at both community and facility levels, and also caregivers and managers, health service managers, to understand what some of the barriers were to the delivery of these services, the uptake of these key messages, how we could co-create, ideate solutions that could address some of these barriers and test those solutions. And I'd mentioned that we had settled in on approximately five solutions. One was counseling during antenatal care. Interestingly enough, this notion that children could hear in utero, that they could recognize the voice of the caregiver, the caregivers, that if the mother was stressed or happy, the child could sense that. Even though initially that idea was thought to be a little, to put it mildly, wacko, people latched onto it because it was such a compelling, powerful message. And we realized that we would take advantage of it to emphasize and reinforce the importance of early childhood development and broadly caregiver well-being as a part of antenatal care. So this was one of the solutions where instead of taking this broad brush and telling health service providers in a laissez-faire manner to just, okay, you have 1 minute, you have 30 seconds, you have 20 minutes, you have the whole day, do your best. We as a group, decided that this sort of guidance was required and it was wanted by service providers. Then I mentioned during childbirth, typically moms are in the facility for a day or longer. And oftentimes they come with a companion who could be an older sibling, who could be a friend, who could be their sister-in-law or their mother or their grandmother, but someone generally comes with them. And in many settings, as the woman is being discharged, the man comes to receive her. So you have these touch points to also offer additional counseling. So just as the child is born, the mother gets counseling on how you can start to talk with the child right from the get-go. You know, you don't need to wait until 3 years have passed. You should start talking to the child. As you put the child to breast, as you start to feed the child, you can start talking. And then as the mother gets moved from the maternity ward, or rather from the birthing room to the maternity ward, she's encouraged to continue talking to the baby as she's breastfeeding. And during discharge, this message is reinforced and demonstration of baby massages carried out. And to give you an idea of how we listened to providers, listened to managers, we learned that the initial baby massage counseling card was not easy to sort of absorb, to memorize. And they said, you know what? Can we reconstruct this baby massage card so that it replicates a step of a physical exam where you go from head to toe? Like, we got it. And so the counseling card was redesigned so that it could be, as Lisa very wisely said, layered on some top of something that they were already tasked with doing, which they had memorized, and would just be a step that would automatically follow. The other solution that we have here, and I encourage you to also start, circling around as well so that you can see the actual job aids. I mentioned the health facility waiting areas, which are generally quite child unfriendly, sterile, crowded, but we were having play sessions where kids could play, where parents could receive some counseling messages, but we realized that the counseling flip chart that was being used was a little too difficult. It was not, it had too much noise. And instead, community health workers or facilitators said, can we just make it simple, very basic, just basic counseling messages, some basic instructions on how we can set up the play sessions. But at the same time, health facility service providers, so clinical officers and nurses, they said, well, guys, it gets so busy. We have to immunize these kids. Sometimes the kids are sick. We need to follow up on them. It just gets too much for us to integrate counseling on early childhood development. And so could we think of some ways to take this burden off of us? And we realized that some of it could be task shifted. So while the mothers are waiting, the caregivers are waiting in the health facility waiting areas, they would not only just receive some basic messages on how they can play and communicate with the child, but actually more structured counseling, especially those mothers who are seen to be struggling a little bit. Maybe they're too young, maybe their vulnerabilities are complex. So helping them, coaching them to play more with their children. And then once they go into the consultation room, the nurse would say, hey, so what have we learned today? Would you mind showing it to me? And if the nurse felt, there was a good message that had been absorbed, let's go to some other, parts of your consultation. But if the nurse feels some more reinforcement is needed, well, that reinforcement would then happen. So in some ways, you're doing a little bit of mini task shifting without necessarily putting the entire burden on another overburdened service provider. And in Kenya, what we heard was that there's already a mother and child handbook. There's already a mother and child handbook. And in 2020, also with funding from the Hilton Foundation and working with partners, we had advocated for including more structured developmental counseling and monitoring content. Previously, it was not really colorful. It was just like not stick drawings, but just like cartoons. And it needs to be visually attractive. There needs to be good messages that healthcare workers can absorb. And they said, you know what? We are so busy. We love having the posters on the walls. We'll refer to them. We'll look at them. But for our everyday use, we want something that we already have. So we decided to use this as our primary counseling tool. And develop an SOP which tells healthcare workers which page to refer to, what messages to provide. And also importantly, emphasize the fact, and it's written right on the cover of the handbook, that this is not just a it's not just a book that you use to keep records. It's not a record-keeping book, but it's meant for caregivers to understand more about themselves and their children. Therefore, this is a living document, and I think as a next step, what we have recommended is that there be an actual sensitization on the entire booklet so that healthcare providers and caregivers understand. As I said, this is not just a calendar for noting your next appointment, that there are these rich counseling messages that they should know more about, and that caregivers have every right to ask service providers to know more about. So these were the solutions, the refined solutions that came from the broader model that I mentioned at the beginning. And I would love for you here in the DC office to interact, ask me questions. Those online, if you could also go to the Knowledge Hub, check out these materials and feel free to ask me questions as well.
For in certain situations where maybe mom just had a baby but needs to go back to work, is there encouragement or opportunity to form like childcare groups, informal or formal or otherwise, and then you also, champion these practices into the childcare groups?
Great question. So not with this body of work, and it's great that Brianna from the Bainham Foundation is here, because one of the ideas that we have co-designed and are testing out in Ghana with Joan Lombardi and the Bainham Foundation is looking at these childcare groups and how we can make them more than safe spaces for children. I mean, it's essential to have those safe spaces, but they need to provide more comprehensive nurturing care. So link them with existing primary healthcare services who are supposed to be looking after these kids, but strengthen that linkage. If there are community nutrition programs, can there be linkages between that and the childcare centers? And when the parents are coming to pick up or drop the children, could that be an opportunity, a touch point for providing some counseling? So that is exactly what we're testing out in Ghana.
I think that booklet example is interesting. And when we were doing those learning reflections, you might remember, we had from South Africa, and one of her reflections was in South Africa, they decided to really focus on that mother-child booklet, get that content in and use it. So it's an interesting question too of, are there particular things that really resonate that you can really focus in on, kind of going deeper as opposed to having lots of activities. Mm-hmm. So I love seeing how integrated the Kenya booklet is. Mm-hmm.
Thank you, Lisa.
Yeah, and it also really speaks to the idea of existing resources, right? I think that's what's really interesting too, instead of just creating something new, something different, but how can we have something that's existing and just make it more functional, more effective, right?
And the key term is functional, because I think what I've always found fascinating is that I've been working in Kenya for 12 years, and the book has literally been thought of as a record-keeping book, like it's an appointment calendar. But neither healthcare workers nor caregivers are sensitized on just how much content, what rich content exists. And while this is a very rich handbook, there are other countries as well which have quite substantial child development content.
But do you think, Debjit, is there opportunity to do more sensitization, I guess, is what you're saying, right? Mm-hmm. Okay.
So sensitization is key. And I think, we have focused quite, strategically on the child development content, but there's so much more. I think that was a key demand, if we can say, that came from healthcare workers. This was great, but what about the remaining 50 something pages? And there's so much more, but they are hungry for a refresher. Because what happens is and I'm being very honest, when partners come, everyone focuses on a technical area of interest and to the detriment of everything else.
When this was put into practice, the manual you have, Was there an opportunity to also embed that into the recording so that when providers are doing their checks, that they've done the blood pressure, they've done this, that they're actually also checking off that they've done these instructions that are then reflected in the book?
Yes.
Is that part of the package?
So great question. So my colleague Helen from PATH is asking about essentially recording if I can say, the new intervention or the integrated intervention. So one of the work streams in which we have been engaged in multiple countries is getting a formal indicator into the health management information system, because unless a service provider is actually tasked to enter data, chances are it will be de-emphasized. At the same time, we don't want to overwhelm service providers with like 50 tools or 50 data points. And I've heard this multiple times that we love and respect and understand and appreciate the importance of this work, but we don't want like another set of 50 indicators to report on. So we have to be very strategic and just choose one indicator: number of children with suspected delay. So if there's a permanent register in a health facility, you note if that child had a suspected delay. There's a remarks column. You note what referral or what corrective action was prescribed, so that when the child comes back, maybe for the next vaccine, for the next weighing, you can immediately say, aha, on the 20th of June, this child came. I noted 2 potential developmental delays. It's been 4 months now. Let's see what's happened. Yeah. Thanks, everyone. And also for those online, I think most of you know me personally, and us, our collective, us colleagues. So please feel free to share questions. The Knowledge Hub will be officially launched. Right now, it's a beta version, but you're very welcome to share reflections there. We will be collating responses and reaching out to you if you have any questions or clarifications. Thanks, everyone. Thank you, colleagues. Thank you. Who did? Okay, sure. Okay, Saurav, can you hear me? You can unmute.
Yes, thank you so much. And first of all, many congratulations for this wonderful initiative. So I was just wondering, I mean, have you captured your experiences on the responsive feeding and the journey of taste for the children?
Sorry, what was the last part? After responsive feeding?
Yes, after responsive feeding, I have asked about your experiences on the taste part, taste component, because usually, ideally, we say that the children needs to give the responsive feeding, but in practicality, the things are not as smooth. So
Yeah.
so in this whole story, the most of the times either the child is underweight or the taste doesn't get well developed.
Right. So I think, yes, we have focused on responsive feeding. And I don't know if you were there for the initial part of the day when we were talking about the journey and the evolution. So when we had our 35 counseling card set, there was significant content on responsive feeding, age-specific responsive feeding content. But again, given just how difficult it was to replicate the counseling package, and given just the amount of new messaging that was coming forth, we did have to make a rational decision to kind of incorporate that in a broader responsive care. So when you're feeding the child, you're playing with the child, talking to the child, making feeding times, fun and attractive, and so the child looks forward to it, and that sort of stuff. So that is to the extent of which we have kind of rationalized responsive feeding within our broader work. But I would definitely encourage you to look up some assets developed by the USAID Advancing Nutrition Project. They have worked to add a responsive caregiving early learning component, as well as feeding of children with feeding difficulties, to the global IYCF counseling card set. And I understand that Elevate Nutrition is carrying that work forward. So I really encourage you to go to the Advancing Nutrition website. You should be able to find some resources there.
Thank you so much. Thank you so much. And lastly, I must congratulate once again and request you that please see an opportunity and touch points to to link these ECD interventions with the path interventions across the countries.
Great. Thank you so much, Saurav. Okay,
Thank
colleagues,
you.
we'll be taken to another breakout session now. Thank you, everyone. Thank you.
So very welcome. We are now in the maternal mental health room. So we'll learn from the first round that we need to speak less and give more time for questions. So we'll try to be more, we'll try to be better. So I'll start the story and then Digit will continue. And all the materials that are here and more you can find on the maternal mental health tab in the Knowledge Hub. So I'll start by talking about what we try to do in the MCH consultations to really introduce maternal mental health screening and counseling in the antenatal and postnatal care services. So this work has emerged as kind of an offshoot of our ECD work, just because we realized based on the research that it's really not enough to just focus on the child, trying to improve child outcomes without checking whether the mother is actually able to implement what we are teaching her. And one of the criteria is her own mental health, right? Is she really listening to your counseling, right? Is she able to, is she interested in what you are saying? And so maternal mental health became very important. And there are quite a few outcomes, negative outcomes, if you know, of maternal depression, including on take-up of following up with health services, family planning, HIV adherence, right? Plus effects on the baby, malnutrition, poor growth. So that's really concerning. The work started really as a request of the Ministry of Health in Mozambique, because they just wanted to do screening of mothers in postnatal care. That was a concern, they were interested. And they already identified that on the tool level, they use a PHP9, which is patient health questionnaire. So we said, okay, that's great. We can try to help you as a technical partner, but we think counseling is also important. So that's kind of our add-on. And we did 2 rounds from 2019 to 2022. We did 2 rounds of piloting in a few health facilities in southern Mozambique. And what we've done is basically to design this tool. I don't know if you guys can see it. And do you recognize the format of the tool? Those who are in the primary health care. What does this remind you of?
Looks like IRCI.
Very good, exactly. And the reason why we use this format is to make sure that it's recognizable to the nurses. So as soon as they look at it, they know how to use it, right? So there are some issues they need to observe when they see the mom, right? This is in Portuguese, but you can find a similar resource in English online. How do they look, the mom and the baby, right? Do they look clean? Do they look well taken care of? Does the mom show interest in breastfeeding, right? That's one of the signs of depression. Does the mom actually look at the baby? How young is the mom? Is she adolescent? Is she HIV positive? And then there are some questions that we want to ask the mom directly. You know, was this pregnancy expected? Does your family support you? Family meaning your partner and the other family members, right? So observe and ask. And within ask, we started with PHP9 as the ministry wanted, but in the second iteration, we went down to 2 questions and 2 cutoff questions, which are PHP2, because we realized 9 questions were too many for the nurses. And so we also realized that the traditional structure of the PHP questions was not appropriate for the mothers. They did not understand. There were loaded questions, right? Because you're asking, in the last 2 weeks, how many days did you have no interest in doing what you usually do, right? It's like you're asking, because I had interest, and also you're asking how many days at the same time. So it's like 2 questions in one. Yeah. So we had to break it down and say, did it happen that you lost interest in the things you usually do? Oh yeah. So if it did, how like was it for a long time or just for some time, right? So trying to kind of simplify, make sure the questions are understood. And then based on the answers, you can decide whether you are going to just refer the mom, or you need to refer the mom, or you can just counsel her, or actually just, you know, thank you for, you know, doing well and let her go. For the counseling, so in Mozambique, we have a station, we have somebody called mental health technicians. Every relatively big health facility has somebody who's called mental health technician, and they're able to receive these mothers who are referred. If you go to rural facilities, you will not find anybody like that. So we decided that we need to give something basic to the nurses to be able to counsel if the mother is not able to be referred, right? And so what we used are the Thinking Healthy visual cards. We've adapted them based on the formative research with the mothers in postnatal and antenatal care to make sure situations that are reflected here are actually the ones that they are encountering in their daily life. And so there are cards for antenatal period and then there are cards for the postnatal period. And the focus on the topics you will see in Thinking Healthy, which is taking care of yourself, taking care of your baby, relationship with your significant other. And then we've added a fourth topic because it came out in formative assessment, which is relationship with others, your friends, your extended family. And so you can see some of the photos showing the counseling. And the data shows that really, if you look, because we started with PNC, but then added ANC afterwards, it seems to be easier for the nurses to do counseling in ANC, screening and counseling. Over 80% of clients in ANC have been screened, but only over 60 in PNC. And you can imagine why if you think about the nature of the consultations, right? And once you got the baby, the newborn, like it's much more busier, so his attention goes more to the baby than to the mother. The detection rates are not very high. At highest, I think we had over 3% of women who were screened detected with any type of depression. But we are not too sad about it because our recent DHS just came out, and for the first time there was a question on depression. They did not target women in perinatal period. It was women 15 to 49 years, and we've got 10% as a kind of national rate, right? Those women, so 3%. If nurses in the busy routine care detect, I'm not very kind of upset about it because we see similar results, for example, for nutritional monitoring, right? We get 6 to 12% for acute malnutrition, depending on the season, right? And we get 1 to 2% through the HMIS data, through the routine data. So there is always like this gap. We've kind of taken this approach and adapted it very quickly to the Ethiopian setting, post-conflict Amhara region. And then we also taken it to Ukraine. In Ukraine, we've done something else. This is in Ukrainian. Just to show you very quickly. We've added a take-home tool. In Mozambique and Ethiopia, it's very hard to give take-home tools. You will quickly run out of money. Not be able to give it. It's not sustainable, right? In Ukraine, now the birth rates are really low because of the war, you can understand. So it's actually feasible. And it's really working as a self-care tool. So there are some activities that the nurse goes through with the mom and says, okay, you know, now that we've learned that you would like some support, what can we do? Let's look at these options, right? There are some breathing exercises, there is talking to your best friend, you know, there is walking in the park, what's feasible for you? So let's select one, practice, and next time I want to hear from you how it went, right? So it's something additional based on the country context that was feasible. And then we are just trying to get into the very intensive and very difficult setting, which is the NICUs. Because you can understand when you have a child who is born with low birth, very premature, or has specific health issues. Maternal mental health is one of the first things that goes down, right? Not only maternal, but also paternal, and you know, like the whole family is basically affected. So we're just trying to think of a conceptual framework, what kind of supports the mother and the family needs when they're in the NICU, and also after they move out of NICU, right? And then doing the follow-up. But it's really in the early stages. And what we're noticing is that really even the basic things are important. The nurse just knowing the mother's name, and the mother knows the nurse's name, you know, interpersonal communication. You don't even need to get into counseling. Just make sure that they're treated humanly is like the first step. So we're kind of working on the basics now in the NICU. And I will ask my colleague to
okay.
to the
Yeah,
group.
thank you so much. Yes, yeah, thank you. So Lana, and I'm just going to speak about some of the innovative work that we have also done in within the DREAMS, or the Adolescent Girls and Young Women program, and also for mothers who are from the post-conflict region of Ethiopia. So the Adolescent Girls and Young Women parenting program that is anchored on this manual was done in Kenya, and this was integrated into one of the PATH HIV care prevention and treatment program that is done in the Western region. And this program is basically focusing on DREAM girls and OVCs, as well as providing treatment services for HIV, people living with HIV. So our main focus here was basically how do we support the adolescent girls and young women who already in that context have a problem or have a burden in terms of how can they provide quality care for their children. So we had this anchored based on group-based interventions that are most impactful, and we went through a co-creation sessions with the girls to identify what challenges did they have in terms of parenting, and how best could we come up with a manual that could help them facilitate those sessions as they go to their sessions, facilitate their sessions and help them in terms of improving parenting practices. And so we designed a 14-session manual, borrowing from other manuals within the globe that were already available, and integrating that with the parenting manual that we developed. So this was being delivered through group-based sessions. The Dream Girls already have a platform in which they conduct routine activities. So they come for counseling session, they come for engagements and other prevention services. So this was integrated within those services, and they undertook a 14 period week engagement, and this manual is divided into those particular sessions. And so each and every session was focusing on a particular area. For example, caring for yourself, helping your child to develop well, nutrition, and responsive care, and all that. So they went all through those sessions, and this is basically a part of the photo for some of the group sessions that they normally conduct, and this is just a write-up that we did once we had completed that pilot. So this pilot ran, and some of the key things that we identified from that was basically improved co-parenting and also positive communication, and also reduced partner violence between them and their significant others. And then within the post-conflict region of Ethiopia, this program was being delivered by DREAMS facilitators. So the girls have their peers who are facilitators, who are trained and now facilitate their session. So that was the avenue that was being delivered, integrating also the community health promoters or community health volunteers who work within those particular communities. And then in Ethiopia, also taking the same concept of working with the community health workers, and within the structured government system and the community health extension workers, also came up with this manual to support pregnant women and mothers who are living in the post-conflict areas, because that is already a burden in itself, and they need more support in terms of how best then they can be able to take care of their children. And so that was developed and delivered through those existing structures. And this is one of the key structures, photo just indicating one of those group sessions that they conduct within the villages. And so something that was very interesting and the approach here was basically the use of storytelling approach. And the storytelling approach is I tell my story, and the other person also tells their story, and that in itself then provides comfort and also sharing and also opening, and in terms of dealing with the mental health issues. And so significant, remarkable depression realized from 44 to 4% in Ethiopia, and increased caregiver ECD knowledge, as well as also just looking at issues to do with the group nutrition amongst the group members. So that is basically what we had here in terms of maternal mental health delivered within the group settings.
And then we just mentioned that kids were, because many moms, even though they are maybe pregnant or they have only newborns, they also have older kids, right? So there were always play groups on the side at the same time, and we train volunteers both in Ethiopia and in Kenya to take care of the other kids at the same time.
Yeah. So one thing that we realized with the manual for the LGYW was this was delivered through 14 sessions, and considering that this is an integrated approach, and we realized that the sessions may be so many, and at the same time they are also very important. So we are currently in a situation of battling in terms of how do we reduce, but also ensure that at least the important things are covered. So that is one thing that we learned, and we are working towards ensuring that it's reduced, but at least covered.
Our time is up, but maybe if you have one or two questions, we can make sure to.
Just in terms of the amount of time that it takes to do one of the sessions or to do the query, because you were talking about the integration, I believe just in terms of the number of sessions, but in fact, it's being integrated into other things that are happening, right?
Yeah.
Yeah. So how much time did it take to do?
Okay, so normally these group sessions, they normally happen within an hour. Either the girls meet once a week or after 2 weeks within the, but during this particular time, there were regular meetings, and the sessions could last between 1 and 1.5 hours, depending on how they collect, how they engage, and how the facilitator also moves.
So it's easier to do. There is a difference between community and facility in context, of course. You know, as pediatrician, right? So community you can do much more. You have more time. Is it be it a home visit or a group session, right? So that was definitely the time we had, and we were using existing structures, but they were flexible enough to accommodate regular meetings of about an hour and a half, I would say. In the facility, of course, you have maybe 10 to 15 minutes for the whole consultation, and then it's good actually because it's much time. So that's why we actually started using PHQ2 to PHQ9 and kind of really making the counseling approach very visual and very kind of simple, streamlined, because you cannot do a lot doing that. That's great.
Thank you.
It's not time to change it. Not time to change yet. Sarah, I think Melanie wanted to do extra minutes.
Okay. Yeah.
A question about the Dream Girl. So is this is an existing program of the government or a partner or?
Okay. Yeah. So yeah, it is an existing program supported by Fed Fund. Yeah, in Kenya. Yeah.
Not only in
many countries. Yeah, orphans and vulnerable.
Yeah. Now.
But it's nice that you aligned with the.
Yeah, we aligned with that.
Because we found that about 15% of those girls were served by Dreams program by parents.
Yeah.
But there was nothing specific addressing their needs as parents, right?
Yeah.
So it was just like a top up to this program. And it's also very difficult. I don't know if you guys, anybody have worked with adolescent girls. After they're out of school, it's really hard to reach them, you know, unless you do door to door.
Yeah.
So using a platform like Dreams, it already had reached them and brought them together, gives them like a leverage, right? So you actually add other pieces.
And it's continuous, that program, so they have the routine of coming.
Exactly.
Ongoing.
Yeah.
Anyways.
They have within those particular platforms, they have a routine and engagements. Yeah.
For the community group gathering, I know Dreams, they usually have like a peer educating them or sort of gathering them. Do you offer training for them on the peer?
Yes. Yeah, the people who deliver this, we provided training. Yeah. In addition to those particular trainings that they received.
You can find a training guide for the knowledge from. Yeah. Thank you so much.
Thank you.
Very long breakaway section.
So yeah, we were just doing introductions with those on the room, and there were not many on the line now as well, so we could also see ask for you all to introduce yourselves there too. So Ellie, do you want to start?
Oh yeah, sure. My name is Eddie Stella from USA.
Thank you.
I'm Brianna Bycroft with the Van Family Foundation, which has a global education fund.
Great, thanks.
I'm Vivian Cheng from Results for Development. I'm Marcia, I work with the Tech company that does ECD programs. I'm Emily Gilkinson with ECDAN.
Troy Jacobs, pediatrician with USAID.
Thanks. And those of you on the line, would you like to unmute and introduce yourselves? Can participants unmute and introduce themselves? Are you able to? Yes, they should be able to.
I'm Jane Lucas. I don't know. Can you hear me?
can't hear. Let's see. Oh, sorry. I think there's the audio settings aren't just set up right. Sorry. Sorry, can you go again?
I'm Jane Lucas. I live in New York City, and I've been so in close, I think, to the beginning of PATH in Mozambique, Kenya, and other countries. And I am absolutely in awe to see the summary of work that's been developing, accumulating the materials on the very, very critical subjects of child health and maternal health. This is exciting to see where you've all come, and I hope it doesn't end here. There's so much work still to be done.
Thanks. Thanks so much for
And I want to thank USAID and also the Hilton Foundation. My first experience with the Hilton Foundation was at a meeting where PATH was one of the multiple groups that contributed to ideas for that meeting. And out of that meeting, it was clear that PATH was really ready to go and had the strongest technical group to pull it off. So I want to thank the whole team. The team is a fabulous group.
Thank you. On behalf of those in the country as well, thank you.
Yeah.
Katie.
Hi, everyone. My name is Katie Janawario. I'm with the Hilton Foundation. I had to join late due to competing meetings, but I just want to congratulate PATH and all the partners and everyone for this amazing launch and just review of the wonderful work that PATH and partners have done. So just thank you so much.
Thank you, Katie. Matthew. Matthew, if you can hear us, you're on mute. We can't hear you if you're speaking. If not, let's just go to next person. I can't say now. I think we're trying to sort audio so we can hear you as well here on the room. Natalie is here with me. And Carrie is here as well. So, all right. We're here to talk about community-based rehabilitation. We have a number of materials laid out here on the table, which you can find on the Knowledge Hub. For those of you online. And did you take the screen share?
I did, sorry, okay. You can put it back.
Yeah, I think I can put it back here. So, you know, if you go to the community with the children with delays and disabilities page of the Knowledge Hub, you'll find a lot of the materials that we have here and more on the table. And so just to walk you through, and if you want to come closer to the table, I hope you can hear me well. You know, I sort of explained when we were in plenary that with the development milestones posters that we were using in health facilities and communities, really we were only finding around 1% of the children that were coming to the facilities with delays and disabilities. But the evidence shows that there are approximately 10% of children in Mozambique with disabilities. And in fact, the evidence further shows us that there are enough risk factors in Mozambique that 60% of children in Mozambique could be, you know, not reaching their developmental milestones. So the question was, where are the children, right? Probably in the community, not coming to the health facilities and not being reached by community health workers either. So we did an assessment in 2018 to identify, you know, where these children were, and learned that this association of people with disabilities in Mozambique, ADEMO, was present in Monaco, the district we were working in Nampula, northern Mozambique, already working with people with disabilities, primarily children at school age for inclusion in schools, and then adults for inclusion in work. What was happening with children under 5? They really were not really accessing them, or if they were, they really didn't know what to do to help these children. So what we did was to adapt a lot of the materials we already had to help the families to learn how to feed their children, how to stimulate their children, how to ensure a safe, hygienic environment around them, and also how to ensure that they were included in society. They were not hidden,
they were playing with others, because in contexts like Mozambique, what you find is that disabilities or delays are associated with spiritual factors. And, inclusion is not really a concept in the community. So we developed this tool. It's in Portuguese, of course, but it's adapted from the development milestones that we had in the poster, but also a tool by the Washington, I always forget these, so I have notes here. The Washington Group Child Functioning Tool. So our developmental milestones are primarily for children under 2, and these tools would enable us to find children with delays and disabilities from 2 to 5 years old. And so based on the screening tool, those children identified with a developmental delay or a disability then were integrated in the program, the home visiting program, which we provided technical assistance to ADEMO to train their volunteers to provide home visits and to educate the caregivers essentially on how to care for children using these tools. You can see here that the volunteers are not necessarily directly providing services to children. Their target group is the caregiver. So this is the volunteer and the caregiver doing a massage to the child after having been referred to the health facility, seeing how the physiotherapist does, and then replicating it at home. Then here's a tool that we developed in the context of COVID to help caregivers support children with delays and disabilities in that kind of tense context that we were experiencing at the time. Children who really didn't understand what was happening around them. But it was then adopted beyond COVID. It's a tool that the volunteers still provide to caregivers, very pictorial, very colorful, and it's almost used for stimulation. It is used for stimulation of children at home because it's so colorful. And moving here, even though they were providing services at home, they still needed to access services in health facilities. And they started, there were 2 main interventions that ADEMO supported. One is to ensure that children who were referred to the facility were actually reaching the facility and then completing the course of treatment. There were main barriers that we identified to that. One was the distance to the health facility. You would typically only find a physiotherapist or a psychologist in the main district facility, which is far from where communities are. And once they reach it, to then go back to the facility every now and then to have continuous physiotherapy sessions is difficult. So for the children who needed the most, right, they were providing allowances so that they could reach those referral facilities. Here you can see a child with clubfoot who cannot be rehabilitated in the community. They need casting, etc. And so they are provided with this allowance to reach the provincial health facility so that they can go on a weekly basis to change the cast and to correct clubfoot. And another intervention is to bring the facility providers, medical doctors, physiotherapists, nutritionists, as nutrition was identified as the main cause of delays and disabilities, to provide these services in the nearest health facility to the communities. We're also showing here some pictures. And for those of you online, for example, I can show this. It's also, can you see? I don't know if you can see. This is the stuff pants. Okay, yeah. There you go. I think that you talked about stuffed pants in the room. What are stuffed pants? Old pants, essentially, that are stuffed with cotton rags, so that they can provide some support for children to stand upright. For smaller children, you can use a bucket, for example, so that they can have some support around them to keep them upright. And then some more evolved technologies using local materials. We provided some support for Rebecom, which is another organization based in central Mozambique, to train ADEMO on how to use pressed wood or bamboo sticks, for example, to do some more elaborate chairs. You can see one as well. So that they can be supported to eat, to play, to learn. And here, for example, you can also see that in addition to having the support on the back, it also has a support here so that children whose legs are, in a scissor format can be trained, over time and continuously by caregivers on a daily basis to correct that. And the earlier they start doing rehabilitation, the higher the likelihood that this is going to be corrected or lessened. Finally, what we do is a little bit more than just train community health volunteers to do this. We have a whole mentoring and supportive supervision post-training program. And that also allows us to find the difficulties, the issues that they face that the intervention doesn't already cover. That's why we then bring, for example, a Rebecom to teach them on assistive devices. We brought Hopewalks, which is an organization to provide club food correction treatment, and also adopted the Ubuntu package. The Ubuntu package is essentially a package developed by the London School of Hygiene and Tropical Medicine. It provides caregiving, parenting support, counseling, and it was adapted to the Mozambican context. Again, to the risk factors that we find there, but also simple language for volunteers to use, very much the materials that they have available to them, the foodstuffs that they have available to them. And then the volunteers provide these group parenting sessions, for example, here in a facility setting. You can see that. So in the health facility, the volunteer puts some play stuff in a mat. Children are playing while caregivers are being counseled on specific activities they can do with children with delays and disabilities. And in doing so, they're also creating a peer support group around these caregivers who did not have them for our assessments. So essentially, these are the interventions that we provide within community-based rehabilitation. I'll show you a quick video so you also get a sense of what these activities entail. I hope that those online can see this video. So I'll maybe stop, here.
Este é o Olímpio Anselmo, tem 2 anos e 4 meses de idade. Foi diagnosticado com a TPM há 8 meses. Nasceu no hospital, mas teve complicações durante o parto. Identifiquei há 4 meses. Ensinei a família a fazer a massagem, estimulações como brincar com a criança, com brinquedos. E também a reforçar a família a frequentar as sessões da fisioterapia. O manito já senta, já consegue pegar os objetos com as mãos. O manito já começou a gatinhar e que antes não fazia.
Por natureza, a Viva é uma ativista que apoia as crianças. Demonstra esta habilidade de brincar com as crianças e dar mesmo muita atenção às crianças.
Sarago, kain toko bergini mo na kain toko kaza kumawa. Yang kusa kaya jauh kuing mas mai kaya ala kadang kumain masasi ni di mana lo akaba, bagus sekarang jauh ni mana oleh masuk pasar kini mungkomiha, siapa recu kini mungkomiha kini koma walenya le turu pati ki, so na apa camilan, desa ini lah, kata ala punta pula, kalai lo kata pula tibes mana lo oni tak pula kanggai itu toko yang baru kata nimu. Kiku sakuru kune akale true yolia utoko kuntu tulasha ni ko kira na mano ne ka ai
A parte reconhece que algumas crianças como o manito precisam de muito mais apoio, pois já foram diagnosticadas com atraso ou deficiência no seu desenvolvimento. Mas mesmo em caso de crianças aparentemente saudáveis, é muito importante fazer o rastreio do desenvolvimento e aconselhamento dos cuidadores em atividades estimulantes para assegurar a detecção precoce de atraso e criar capacidades em pais para desenvolver e estimular suas crianças. Assim, A PAT está a apoiar o Ministério de Saúde a trabalhar em todos os 3 níveis para dar resposta a crianças como o Manito, a crianças com alguns fatores de risco e a todas as crianças que usam os serviços de saúde.
Bem, quando fala da importância e benefício do DPI, eu penso que é de extrema importância, porque um dos elementos que o DPI traz é garantir um desenvolvimento saudável da criança. Porque quando a criança não recebe esta atenção dos pais ou uma estimulação apropriada durante a fase de crescimento, ela pode ter sequelas a médio e longo prazo. Não é? Quando elas são estimuladas, elas podem recuperar-se facilmente.
A expectativa da província em relação à expansão é que na abrangência dos 23 distritos da província e as comunidades ao redor das nossas unidades sanitárias, que é para melhorar o acompanhamento das nossas crianças a todos os níveis.
Falar sobre parcerias respeitosas são uma prioridade nacional para a PAC. O foco dessas parcerias, para nós, é, em primeiro lugar, o governo, e, em segundo lugar, as organizações de base comunitária, no caso da DEM.
So that just gives you a taste of the activities that are conducted. Obviously, you could see there illustrated several other activities that we talked about earlier, playbox activities, counseling parents at all levels, right? Those indicated support services, those that are at risk, and then universal health services, more kind of a low touch approach to just preventive care, promotive care, etc. So, I mean, if you have any questions, happy to answer any. I hope it gave you a little bit of more of an immersion of how you use these materials and how this amazing partner that we're working with in Ademo in the Monapo district, which is one of 23 districts. You could see the chief medical officer saying we want to scale this up, right? So yeah, if you have any questions, happy to answer. Let's see. Well, I can see the chat. Was I very clear that you don't have any questions?
Yes, maybe if you can just explain a little bit the partnership with the government, how the government has been facilitating the work with other parts.
Sure. Well, as you know, our interventions are health system based, right? We don't have staff providing services. We provide technical assistance to existing system staff to provide those activities.
We're just returning to the main room.
Okay, there. So yeah, the government health workers are the ones delivering the playbook sessions, the counseling sessions, developmental monitoring with the milestones. And then the community-based organizations are a complement to that, right? They're reaching where the system doesn't reach. So even as we work with community-based organizations, we're linking them with the district health services, not just health services, but also social action, because as you know, if malnutrition is one of the main causes, we can't just resolve that by providing nutritional counseling. So sometimes they need social protection programs, sometimes they need agricultural, they links with agricultural activities. And that's what this demo team does. They're from the community, they know these families and the situations that they encounter, and so are able to link them up with the different services. And, always linking up with the government, having the district health workers conducting the outreach activities, and being able to refer children to Ademo and vice versa.
So the going back to the medical officer in the county, and he wants to scale this up. I mean, it looks very doable because, you're talking about duplicating some forms, and the interventions, for the most part, can be created within the community. And so, do you have a sense of what the cost of scale-up would be?
We have, let's say, okay,
we do this work through sub-grants to IDEMO, right? And to cover anything between 9 and 12 months, they would typically have a sub-grant of about $40,000, which allows them to pay allowances to what they call the activistas, the community health workers, allows them to provide mentoring and supportive supervision sessions, because we train trainers and supervisors, and then these people who work with ADEMO, our salaried staff, through the sub-grant, right, are able to then provide these services. So replicating this to other districts could mean a higher initial investment, right, to train the trainers and the supervisors to provide mentoring and supportive supervision support. But then from there on, like a 9 to 12 month intervention costs you less than $50,000 through community-based organizations.
Okay. Very nice.
Yeah. Any questions if you want to unmute?
And are there your selection of ADEMO came from
the fact that they were there already,
their existence?
Exactly.
Yeah. And so they maybe only are in that particular location. So you'd have to look for other partners, or they would have to scale up as an organization to reach other areas.
So ADEMO is a national organization for for people with disabilities, but they have like different chapters per province or per district, etc. ADEMO Monaco, which is the district we're working with, supports Monaco districts and 3 others. We actually just conducted trainings of trainers for them to scale up to those other 3 districts. To then do that in other districts or other provinces, you would have to identify if those chapters are active or not active, what's needed to be strengthening them, or maybe there's another organization that is already accessing these children, and then you provide them with training, with the materials to replicate it. Yeah, but it really is identifying the platforms that exist already, kind of piggybacking from them, which then allows you to not have to put in so many resources. And it's kind of sustainable because they're from the community, they have the knowledge, they're not going to leave the community, and they become references in the community. They are sought out by community leaders who identify children, by parents themselves who hear from the others.
Welcome back. I believe that you had a very good session, a deep engagement during the breakout.
Yeah,
yes.
I hope you really got to kind of experience what happens in the field, what some of the lessons that came out were. There are some very interesting questions where I was, in terms of replicability, sustainability, etc. Yeah, we're very passionate about this work and the partners we work with, and I hope you got to, and the children, obviously, that we serve, So, yeah, great to be able to share that with you. So really now we'd just like to hear from you, hear your reflections. This is what we wanted to share with you. We've shared with you the Knowledge Hub, we shared the evolution of our systems, we provided a deep dive on some of the innovations that we implemented. So yeah, what do you take home from these? What do you see as the use of some of these tools, materials, and approaches? Do you think that they're applicable to the work that you do, and how? So yeah, it's open to anyone who would like to just to share. Start by building those relations and really sensitizing leadership. Because you can train health workers as much as you want. It doesn't mean that they'll keep continuing to do it when you're not there. And that's what we experienced in the first few years of our intervention. And that's why the ECD exercise came. We didn't really share a portion of the work that we do with ECD because I we focused on the systems and trade materials, etc. That was a whole other objective of the ECD work, which was to work with our facility directors to understand first how you improve provider motivation, because obviously what's the question we hear, the answer we hear every time I ask a question. I don't counsel parents on ECD. I don't have the time. I have a big queue. I have other interventions. This is important, but other things are too, right? And there are important things that motivate a provider to deliver a service. Having a prompt in a wall, for example, or on their desk to remind them of something that is important to do, is one. The other thing is to have indicators that they have to report to, because ultimately that's how performance is assessed. And secondly, is how their leaders, or thirdly, how their leaders hold them accountable for delivering a service. So if the only thing I'm looking at is immunization coverage or adherence and retention, or things like that, or maternity, health deliveries, institutional delivery, why am I going to focus on counseling on ECD? And then you say, okay, let's put a counseling indicator on a register. Doesn't really help, because the answer is always going to be yes. So support supervision becomes important, and building rapport with the health provider and trust becomes important. So yeah, it goes much beyond materials and tools and training practices. But I would say engaging leadership from the start, even in designing interventions, is important. Monitoring the implementations and including them in supportive supervision, because the reason why we see these innovations that we just started in the breakout rooms is because we were there. We could see what was working, what was not working, how do we adapt, how do we add, who are we missing. So, I mean, if leaders are also not being there and seeing that, then why? So it starts at all levels: community leaders, health-assisted leaders, district, provincial, national leaders, and it's really, you cannot underestimate the importance of that. So yes, leverage the platforms that exist, yes, but engage leadership. So those platforms are seen as an opportunity to, not miss the opportunity to ensure the whole development of the child, not just survival, thrival, caregiver mental health, all these things. Yeah, it takes a lot of time, sensitization, etc. So that needs to be taken into time, resources. All other reactions from the faculty to the questions or comments that were raised? Not maybe other. Anyone thinking of taking on these tools and leveraging what you already do?
For online response. Sorry, I'm just stepping in the back now because I want to clean your next so that we can reduce the source of feedback. But regarding the question was raised about what happens next, these tools will be used. But part of it is, I think, the collective our responsibility, because even now, we still hear talk about planning around older packages or materials that have been adapted and tested. So I think the collective us will be great. And several we've already said that you'd be interested to publicize and share with colleagues and friends. So I think that'll be a but folks know that this exists, that some adaptation is happening. If you look at the language, so nicely. It's just not material. This tells you a little bit about the logic, like how this adaptation happened, why this adaptation, what did we learn? That there's a way to go on the great life. So I really hope that we treat this as a living repository, and that this would sort of be this would essentially be a resource that takes us from the pathway of adapting something that's more abstract, more generic, to materials that have actually been tested and with full potential promise for further scale. That we just sort of
I just wanted to share some thoughts about this work and today. Is that feedback in? It's okay. All right. It's really distracting. Yeah, sorry. But I just thought that work really and talk about that bringing back down a little bit to think about the children that actually benefit from this work. And there are thousands, tens of thousands, over the history of the legacy of this work and other projects that we've done in various countries using the ECD models that we've seen today. And that is just breathtaking if you really stop and think about it, the impact that we're making with children themselves. And I know my colleagues in Mozambique, in Kenya, working in Ukraine, are just so passionate about this work for that very reason, that they're changing lives. They're giving opportunities to children that might not otherwise have it. And the takeaway today for me is that this work will be amplified because of the Knowledge Hub, because of all of you in this room that will hopefully go forward and take this on, share these materials, encourage and incorporate your colleagues to these models, these counseling cards, these posters, and what they're already doing, and just keep this work going. And for me, it's no less than inspiring. And I'm just honored to work with Debjit and Melanie and Lana and Dickens and all the rest who have really piloted many of these things in the field. And we're so grateful for all of you for spending your Friday morning with us and helping us move this work forward. So thank you. And I just want to give another big round of applause for our technical leads. Sarah, for those of you who don't know, Sarah is the operations director for a PhD at that. So she's the backbone of all the work that we do, as is Natalie, who has been taking the around and guiding. She's our program associate. So I think Sarah really wrapped it up really well. If I would say anything like going forward, I think there's still evidence to be generated. So as you take this work further, do consider, you know, you development. I think that the work with children with disabilities like this 3 months, it's really, really impactful. Work that you do at the base of pyramid is something that takes much more work to do. And the type of things that you want to see is also smart. You know, you think that by doing those such services at the base of the pyramid is going to change development. Perhaps not necessarily, but we do change the nurturing interaction between parenting. So parenting, knowledge, and systems change are really that we do see. So, but we do recognize more evidence needs to be generated. So encourage you all to think about that in your programming. And Debjit.
Delicious lunch. But I do think as we are reflecting on our work, just it's not just the technical work, but the backbone. I think I share that father because we have been, but there are other folks in this room now We're still, I think, the post-COVID world, kind of trying to understand this hybrid environment of events. And there were quite a few glitches today. I apologize to those online. Some people didn't receive a link or received a link, so there was feedback. And then, we have to tinker all these things. So thank you to Natalie for with your characteristic good humor for not just going bonkers because we're just looking at all these models. William, our facilities director, thank you so much for, again, just running around and helping us troubleshoot all these issues that we've been having. Like, even though we thought yesterday we had it, clearly, reality is a little different. Thank you, William. And I today morning, it's like William and I were texting at 6, we're now on my way, got this. It's just so important to have someone like William, our actual, to ensure that we are able to carry out. There's so many other things. Just wanted to recognize people in the room and not in the room. But also, I don't know if Matthew Fry is still. Oh, he had to leave. So many of us know Matthew, and I refer to him as the OG. I don't know what OG is, but sure, hopefully. So he is our OG for this work. Like, it was so much of his vision, his drive, his humor, his wicked sense of humor that really helped push us, think creatively outside of the box. And I'm also very grateful that I've seen Bernadette, I've seen Matthew, so many friends with whom we have worked and who really encouraged us in this particular direction. So this wasn't some sort, it's kind of like a high school reunion for us. Very
Hi, for participating today. I hope that you found this an insightful session. We wanted to be able to share these learnings with you and yes, not take them with us. Because, ultimately we want more children to and caregivers to have access to these interactions. So, like this serves, right, Natalie? Yes. So it serves in a cafeteria feel that more chance for us to interact as well, and I think that answering questions you may have.